We've got quite a bit on the agenda, so I think we'll go ahead and dive in. First, thanks to each of you for being here today. My name's Stephen Bell. I'm a co-founder of the Bow Foundation, but in this crowd, I'm better known as Emily's husband. You all know Emily Bell, my wife, and then obviously Duke and Alice Fox are our co-chairs and co-founders of the Bow Foundation. Thank you each for being here today. I got a few thank yous to work through really quickly. First, I want to welcome families with GNB1. We have a researcher and some families who have GNB1, which is a closely related condition to GNAO1. They're here today to learn because they're going to start their own family foundation journey. And so we want to work together towards that journey together. Secondly, just a couple thank yous. Obviously, Elizabeth Hausman does a great job with our social media. Jordan and Jacqueline Dembemishek helped with the great volunteers, and they coordinated a lot of the resource and packets that you got today. Dan Habib helped us a lot with the AV and a lot of the coordination behind the scenes. And then obviously Alice Fox and of course Emily did a great job coordinating this. Emily and I have 3 children. Obviously our superstar Madeline is well known in this room. We also have a 5-year-old named Theo and a 2-year-old named Jack. And a 4th on the way in October, in case you haven't noticed when you met Emily. But kids say the darndest things, right? My 5-year-old Theo the other day looked at my forehead and said, "Dad, you've got a lot of tiger stripes setting in." Talking, of course, about the wrinkles on my head, which I was not thrilled at. He redeemed himself, though, because later that day he said, "Dad, I'm going to be a scientist," because scientists never quit. And I think that's true. That's what we're all here to do today. And I think that's powerful, right? When we started the foundation as a network, we had 2 goals, right? Build a better tomorrow for patients and convene a community where people who are going through the same struggles can meet and learn and grow. That's really what we're here to do today, and it's not possible if no one shows up. So thanks to each of you for being here. Thanks for being a part of this journey with us. You're not here to hear from me. You're here to hear from your peers in the medical community, and that's what we're going to drive towards this morning. For those of you who are speaking, I just have one ask. There's 20 minutes for each speaker on the agenda. So if you could do your part to help us keep on track, I'd appreciate that. For the families with little ones, we have a room right across the hall that's live streaming this conference as well. It's a great place if you need some respite or if you just need a break, you can still stay plugged into the conversation that's happening. The Wi-Fi code is on the registration desk that you joined. And then also the restrooms for the ladies are right there, and for the gentlemen are right by the elevators on the back side near the windows. So why don't we go ahead and dive in. I'm pleased to welcome Dr. Erika Axeen. She's a pediatric epileptologist and professor at UVA. She's also one of our great scientific advisors on the foundation. So please join me in welcoming Dr. Axeen.
All right, good morning. And I want to say thank you to the Bow Foundation for coordinating all of this wonderful. It's awesome to see so many faces, so many familiar faces, and hope to meet many of you later today. So I'm going to be talking about epilepsy and GNAO1. So as you mentioned, I'm a pediatric epileptologist, so my work is mostly clinical, but this has become more and more an interest of mine. And I have met a lot of families through my research work, but also clinically. So this EEG here, I know for a lot of you, this looks like squiggles, but this is an EEG of a patient that I care for. This is an example of a 2-year-old, what a tonic spasm looks like on an EEG in a 2-year-old, which unfortunately does happen quite a bit. So I think, in talking about the clinical aspects of the disorder, nobody really needs to be introduced to what GNAO1 is, but this is where a lot of us start, is looking on OMIM, the online Mendelian and inheritance in man, to see when we hear of a rare disorder, how does this present? And it's still, I know it looks small, it's down at the bottom, but still really they say it's either a developmental encephalopathy, an epileptic encephalopathy, or a neurodevelopmental disorder with involuntary movements, which is still true, but we know a lot more about kind of the finer parts of that and the spectrum of the disorder. And so when thinking about the clinical manifestations, these numbers are from the 2021 survey that I did, but I think they still mostly hold true, is that we see epilepsy in about half of kids with GNAO1. We see a movement disorder in about 3 out of 4, maybe a little higher, depending on which population you're surveying, and then an overlapping of both the epilepsy and a movement disorder in about a third. But really, more recently, we're thinking about it in even more buckets, and some even more ones I think we'll hear about later from some of the other presentations. But the part that was first described was this early onset developmental and epileptic encephalopathy. And sorry, some of the words got cut off there, but this is the DEE that you'll see all over the publications, and I'll talk a little bit more about what that actually means, since I do know we have a mixed audience here. The other very commonly described phenotype is the infantile or early childhood onset movement disorder, neurodevelopmental disorder, with or without epilepsy, and epilepsy can be quite severe or could be quite mild, a single seizure. And then a third very interesting category that's been recently described is a milder later childhood or adult onset movement disorder with variable developmental status, plus or minus intellectual disability, and maybe seizures, but mild. So even 3 bins instead of 2. So I want to talk a little bit about some of what does this mean when we're talking about encephalopathy. So a developmental encephalopathy is not something you'll see as much on its own, but it is a separate and distinct thing that we should consider in GNAO1. So really what it means is developmental delay and or intellectual disability. So we can't use the word intellectual disability in very young children, and so developmental delay is simply what it describes, a delay in reaching your milestones. And then at a certain age, we're able to call it intellectual disability. Usually with the neuropsychologists I work with, they say about age 6 or 7, it becomes clear that it's no longer developmental delay and you can call it intellectual disability. So in this case, we're thinking the variant in GNAO1 has caused this developmental impairment, developmental delay or intellectual disability, and that is a developmental encephalopathy. And they may or may not have seizures, but the idea here is the seizures really are not impacting the trajectory of the development as much when it's only a developmental encephalopathy. However, what we're worried about often in GNAO1 is the developmental and epileptic encephalopathy. So this is a concept that's been described by the International League Against Epilepsy as a situation where the seizures are directly impacting the development as well. So this is similarly caused by the genetic variant, which also has a developmental impairment, but the epilepsy is another added, I don't want to say bonus, but another battle that we have to fight, right? So it's the seizures and the epileptic activity on the EEG. We often think that the spikes themselves in cases can contribute to this. So this does impact the trajectory for the diagnosis. So some of you may not be able to see this too well, and know it looks like a lot of squiggles. But for me, this is another patient with GNAO1. And what I see here, this is a 4-year-old who is awake, and there are lots and lots of epileptiform discharges. When I look at this, it doesn't look like, oh my gosh, that's someone with GNAO1, which is often the case, is that the EEGs are not specific for GNAO1, but consistent with it. With an epileptic encephalopathy, sometimes there's an EEG that tells us a clear subtype, so infantile spasm syndrome, or Lennox-Gastaut syndrome, which is a little less common. But this is kind of the epileptic encephalopathy not otherwise specified. So there's lots of multifocal spike wave discharges. And it's this finding, in addition to the seizures, that we do worry about impacting kids' trajectory. So as a very visual person, because of my EEG reading, it helps me to see this graphically. You'll see in the white line what a neurotypical developmental trajectory might be, reaching your milestones on time and an eventual plateau when we reach our kind of best self. In a developmental encephalopathy pictured in the yellowish green color, what you'll see is that differs from the neurotypical trajectory, is that the development is somewhat slow. There may be ebbs and flows, potentially even regressions in a just developmental encephalopathy, as some of the parents here well know, is you hit an infection, hospitalization, perhaps a movement disorder exacerbation, as you can have stagnation, plateauing, or even regression as part of that. With a developmental and epileptic encephalopathy, you see the same, and that's quite common with that, is that perhaps you develop a new seizure type, and unfortunately those children lose skills and then potentially regain them. But ultimately, the trajectory is impacted by the seizures themselves and is separate from the developmental trajectory. So really what we all as clinicians, researchers want to think about is how can we move that red line for the developmental and epileptic encephalopathy up closer and closer towards that neurotypical line. So I'm going to talk a lot about electroclinical syndromes, which is really, I'm trying to put the epilepsy into bins that are well described. So I'm thinking about what age did the seizures start, what does the EEG look like, what seizures occur, and what is their developmental status. So when looking about, I think the really cool thing is in the last couple years, there's been a ton of papers talking about different and increasing numbers of patients described in the literature. So I was looking solely at those with epilepsy, but I see since 2022 that at least 50 new cases of epilepsy have been described. In such a rare disorder, of course, sometimes it's a new description of the same patient, and that's sometimes a little hard to tease out. But I think all said that there's 136 descriptions of epilepsy in the literature, which is really helpful for us to kind of understand the spectrum, with 59 coding variants, that present with epilepsy, 56 of those with unique protein changes. So more and more, and of course that also increases not only the spectrum, the number of variants, but the spectrum that we see with the epilepsy. But we still see that the vast majority do fit into that early onset or early infantile developmental and epileptic encephalopathy. So most typically when we're using that, we're thinking of seizures that start within the first 3 months of life. A lot of times it's even, within the first day, the first weeks. I think teasing out exactly what day the seizures start can be challenging, and a 38-weeker that started having seizures at 2 weeks of life, the brain is the same as a baby that's 40 weeks having seizures on the first day of life, right? So some of those nuances of the actual day, not so important, but really the fact that it does happen very early, most typically within 3 months and often within the first year, and about 64% in those described in the literature. This is lumping together, for those of you that are looking at some of these papers, this is the EIEE, EOEE, Odahara, West, infantile spasm syndromes. That is now all pretty much lumped under the developmental and epileptic encephalopathy, although infantile spasm syndrome, we do try to identify that specifically if we can, because the treatment is specific for that, but they all fall under the umbrella of developmental and epileptic encephalopathies. And then there's also later onset epilepsy. So this is a lot of times seizure onset between 4 and 14 years, generally a bit milder, although it still can be medically refractory. And oftentimes this is more difficult to describe exactly what epilepsy syndrome it is, and that's common in epilepsy. We can't always tell our patients that you fit into a syndrome. These can be focal or generalized seizures. There are quite a few that are described as just focal epilepsy. The generalized epilepsy that is less commonly described, but there is an interesting case with very classic absence seizures that we see a lot in non-GNAO1 related epilepsy, and then a couple cases that fit into more of a Rolandic, or now we call it selects. So these are epilepsy syndromes that child neurologists in the room see all the time in other children, but less commonly in GNAO1. So altogether, DEE versus the non-DEE epilepsy. And so putting these into the kind of bins that we all like to do is we have the early onset or early infantile DEE, which happens before 3 months of age, versus the non-DEE 3 years or later. There's specific EEG characteristics within each of those bins. Again, none of them specific for GNAO1, but do fall into either or category. So things like burst suppression, hips arrhythmia, those are consistent with epileptic encephalopathies, and things that will tell us, oh, this is an early infantile DEE. But things like focal discharges, generalized discharges on their own may not tell us exactly what type of syndrome they have, but we can usually use the EEG to put them in one of these bins. But non-DEE can also have a totally normal EEG, so that's something to look for. The seizure types within the DEEs, things like epileptic spasms, tonic spasms, which are related seizure types, tonic or atonic seizures, more frequently in a DEE, but focal seizures, generalized tonic-clonic seizures could be either. And if you have a typical absence seizure, more likely a non-DEE epilepsy. Developmental status, nearly all patients with GNAO1 related disorders have some sort of developmental impairment, but if there's normal development or nearly normal developmental milestones, it's going to be a non-DEE epilepsy. And then the movement disorder, which we talk about a lot with GNAO1, the non-DEE, that's usually their primary phenotype, is a often difficult to control movement disorder. And with the DEEs, they may or may not have a movement disorder, although most of them do have quite significant hypotonia. Okay, so what we see is that early infantile DEE is the most common, and it's typically medically refractory. Some with DEEs have difficult to control seizures in infancy, but there's a number of reported cases where that improves dramatically, even though they have the infantile spasm syndrome, very difficult to control seizures. There are some where they become seizure-free by early childhood, which is exciting. I did not see a specific genotype that's more tightly associated with, but perhaps with time that will become clear. And I think what's exciting to see is the broader phenotype that we see with milder cases with only a single seizure or well controlled with a single medication. And then we're also starting to see some rare presentations of childhood epilepsy syndromes. These are the syndromes that we see very commonly in child neurology clinic, but has less frequently been described in this condition. So treatment, unfortunately, we still do not really have a best anti-seizure medication treatment or anything that's truly disease modifying. I think for those children with infantile spasm syndrome, using a top-line medication for that, steroids, that's considered generally a disease modifying thing, but steroids in general and GNAO1 is not something that's going to be disease modifying just if you have infantile spasm syndrome. But I think it's pretty clear to me that these patients are often predestined to either respond fairly well to either a single medication or the first or second medication. If their epilepsy is milder, it may not matter which medication we use, or they're going to be medically resistant. And figuring out both of those, why they are different, is of great importance. But the reality is most patients end up on a lot of medicines, and I probably don't have to tell the families in the room this, but it's average of 3 medications at a time with trying up to 8 medicines, and I know some have even tried more. So commonly reported medications, I mean, nothing here is specific to GNAO1, but these are the kind of more frequent ones I see reported in the literature and ones that I've used clinically. When I have interviewed families about, which medicine is best, a lot of times they just look at me and they're like, I don't know, nothing has worked. Or if they pick out one, every family picks a different medication as their favorite. So CBD oil, lacosamide, topiramate, clonazepam, ketogenic diet, but others will say that was the least effective, which it makes it really, really difficult. And I think one of the things I've struggled with clinically is that it's so easy to add medicines. What's really difficult is to take them away. And a lot of families really struggle with the burden of lots and lots of anti-seizure medications and the side effects, and sometimes the side effects can be worse than the seizures themselves. And so I've had the experience of, an emergency situation, kids end up on 4, 5, 6 medications, and then we spend time in clinic trying to peel those medications away. It can be really, really challenging. I'm sure many of the researchers in the room are aware of this paper a few years ago of perampanel. We call it Fycompa as, quote, precision therapy. I'm not sure that it's truly precision therapy, but Fycompa is a AMPA selective antagonist that is an anti-seizure medicine. It's the only medicine that has this mechanism, which is interesting. It's always, in epilepsy, we always want to try something with a different mechanism of action to see if that somehow works better. And the patients, this was a group in Europe that's looking at a bunch of different cases. Probably some of your patients of the people in the room were included in this. And they found that of the 4 patients they looked at, they had a pretty phenomenal response. These kids were 2 to 7 years of age when they started on it. Here in the US, it's technically FDA approved for 12 and up, which, so it's not a medicine that we often reach to in infants or young toddlers, which is when the epilepsy in GNAO1 is often very difficult to control. So, it's one of those, the devil's advocate for me wants to say, is it just that, the most effective medication is the last one you try? So was it that? But certainly children becoming seizure-free is something to take note of. So I'd be interested to see if others in the room have had effect with Fycompa. And And then thinking about other ways of treating seizures, I've talked before about using the ketogenic diet, which does seem to have mixed results. A lot of families feel like it's helpful. Others look at me like, I have no idea if it was helpful. And some did not find it helpful at all. I still think it's something to consider, especially because it doesn't have those cognitive side effects, the sedation that we see with the anti-seizure medications. It's often something gets added on in the first year of life when the seizures are difficult to control. Vagal nerve stimulators are another way of treating epilepsy without having the cognitive concerns. And I know there are patients with VNS-in. I've not heard of any that have had an astounding result with it, but still something to consider. And then, of course, most in this room know what DBSs are, a deep brain stimulator. This is also approved to treat epilepsy. Now it's been over 10 years since it was approved to treat focal epilepsy in adults, showing about a 40% reduction. 40% had a 50% reduction in a year. We do drug studies and device studies in a weird way, but generally a good response, and then a continued response over time. And this is what you see in neurostimulation, is that you may not see improvement immediately, in a few months, but 6 months, a year, and even 7 years after implantation of DBS, these patients with adults with focal epilepsy had improvement. It's been used now more and more in LGS, in adults, and now in children. There was a paper from the Pediatric Epilepsy Research Consortium here in the US showing that a lot of the bigger pediatric centers are starting to use DBS in Lennox-Gastaut syndrome, and it's overall probably a little bit better or similar effect from the vagal nerve stimulator, but certainly interesting in light that a lot of the patients with GNAO1 are DBS is indicated for their movement disorder as well. So I'm interested to hear from people that have both epilepsy and a movement disorder, whether it has helped their epilepsy. All right, so I still do have a study open. I'm enrolling patients. I'm interested in kind of deep diving into their epilepsy. So if there's anyone still interested, email here, or you can send me an email to get involved in my study. Just trying to learn more about these patients with epilepsy, looking at their EEGs, their MRIs, and parent surveys. So in summary, I think that we are starting to see increasingly clear epilepsy phenotypes with the early infantile DEE versus non-DEE epilepsy. And unfortunately, there's no single best medication or a targeted treatment. Our ultimate goal is really disease modification to move both those red and yellow lines up and move them together to minimize the impact of the seizures, but also the genetic variant as well. So with that, I want to thank the Bow Foundation for inviting me to speak. I really want to thank the families that I've worked with, both on the research side and in the clinic, that are teaching me about this disorder. I've got my team at UVA that I'm working with, and my mentors. So I'd be happy to take a brief question. I'm supposed to be a good model here, and I left 1 minute for questions. So anybody have any questions for me?
Just super quick, I guess. You have CBD on your slide. Is that Epidiolex or just any CBD?
Yeah, so I think we tend to lump that together when talking about it. In the U.S., our CBD oil that we prescribe is Epidiolex, and I think that's what a lot of our clinical experience is. However, there's certainly people are getting CBD oil from lots of different places. I think the challenge with non-Epidiolex CBD is that we don't so much know the dose, and so I wonder if a lot of that is underdosed. I think things like Haley's Hope and those types of CBD, they can be very effective. It's just difficult as a clinician to know the exact dose and whether they're underdosed or why it is or is not working. Mm-hmm.
There's a quick question online about quick question online asking about just a clarity about your point about Perampanel. A parent asking, I think, what you're trying to say.
Yeah. So there's a paper showing that perampanel was effective in 4 patients, going from having seizures to no seizures. So that's really intriguing to see if that's true across broader populations. My point of skepticism was just wondering if it was any medication and it was just the right age that their seizures were perhaps getting better. But it is a unique mechanism of action because it's an AMPA antagonist that other anti-seizure medications don't have, which reduces glutamate, and there's probably many other neuroscientists in the room that could maybe explain why that does something in patients with GNAO1. But I think something for those that have epilepsy that haven't considered that medication to consider trying.